Good afternoon. Welcome to the virtual town hall for April 10th. For the duration of this meeting, as we have before, we've suspended our mask policy here in this auditorium, in this empty auditorium, so you can better understand us. And we'll continue here with social distancing times about 5. Thank you for joining us today. We're in about week 4 of the pandemic, and this has been a very challenging week, I think, for everyone here and across the nation. Tuesday experienced the highest single day death toll in this week in New York and New Jersey, and also New York and New Jersey also experienced their worst days. In Michigan, we now have over 20,000 COVID-19 cases, which is the third most cases by state behind New York and New Jersey. While this is sobering news, I do want to address some positives. Looking across the state, Washtenaw County has had a relatively low number of cases. And I think without doubt, the efforts that have been made by all of us and all of those who live here around home protocols and social distancing really seem to be having an impact. I know working remotely or not being able to do lab work or research or whatever you usually do in a normal world is very difficult and challenging, but I do truly think it has made a difference and will continue to. And it will have a significant impact over the trajectory of this disease over the coming months. So I cannot emphasize too much the importance of staying the course with staying home from work and social distancing. We all depend on that, from all of us. What we're seeing in our health system is also encouraging. Our ICU census has been well managed with the addition of significant ICU capacity put together in record time by facilities and others. The date that we think we'll reach capacity in our hospital for general beds and ICU beds is later than originally anticipated, and you'll hear more about that. And we've currently put on hold plans for the field hospital because there is some possibility we won't need to have the field hospital. We're also seeing more discharges on a daily basis as our healthcare workers are learning every day how to best care for patients with COVID-19. It truly continues to be an all hands on deck, environmental services, facilities, security, supply chain, pathology, patient food and nutrition, all the clinical and support staff, and so many other groups who have come together during this pandemic. I and all of us can't thank you enough for all that you've done on the front lines and behind the scenes. It's been an incredible team effort, and you all deserve to be commended. And the days and weeks ahead will have many challenges, continuing challenges, some that are known to us, and undoubtedly some that are unknown until they present. We're still operating on a day-to-day basis, but we use the information and data we learn every day to make informed decisions. Today's agenda includes Vineet Chopra and a few of our frontline staff from the RICU. Vineet has a special announcement that we're all excited about, thanks to the generous donations of so many in our community. Now, Jeff and Vikas will provide an update on census projections, transfers from other hospitals, and our ICU capacity.
Good afternoon. I'm Vikas Parekh, Associate Chief Clinical Officer for our adult hospitals and Medical Director for Capacity Management. First, I'd like to update everyone on the current state of discharges and trends within our COVID-19 population. So as of yesterday at midnight, we had discharged 178 patients home or to a nursing facility. We've had a total of 424 hospitalizations, 32% of which were transfers from other institutions, mainly from our peers in the Detroit metro area. 25% of the patients overall who've been discharged had an ICU stay, but of our transfer patients, 64% of them have required an ICU stay. On the other side of this slide, I show some data around what has been going on in the local community. The take-home message there is that Washtenaw County and Livingston County have really seen a dramatic decrease in the growth of positive cases, whereas our neighbors in Wayne, Macomb, and Oakland, they're also slowing down, but a little less quickly than we are. So before I go into projections, I think I wanted to ground everyone in the fact that it's hard to make predictions, especially about the future. And sometimes the future isn't what it used to be. And that's basically a prelude to some good news. When we originally projected what was going to happen, we were tracking very well to the light blue original projection curve that you see here. But then about over the course of this week, you see that our actual, which is the dark blue, kind of made a dramatic turn, slowing down a lot. And that really reflects what you saw there in the local community. This is about 2 weeks after we closed schools and started social distancing, which is when we'd expect to see some impact from those interventions. So what that translates into is a much better outlook for capacity over the next 2 weeks. This is a look at our ICU capacity. I think it's worth noting two things. One is the curve is relatively flat now. We expect a little bit of growth in our ICU census, but not dramatically. But it's still well above that dashed line of usual ICU capacity. Through a tremendous amount of work, we've more than doubled our ICU capacity and are running almost 180 to 200% above our typical ICU capacity. And we expect that to continue for some time. These patients will be in our hospital for a long time before that census comes down. When we look to general care outside of the ICU, this curve is relatively flat, if not slightly decreasing over time. We expect this census to be relatively flat and may start to see a downward trend as the balance between fewer new admissions and step down from the ICU kind of equilibrates over time. So with that, I'm going to pass it on to Jeff, who's going to talk you through national and state data.
Thanks very much, Vikas. Thanks for allowing me to be here and make a few comments. So as Marshall said, cases continue to grow in the United States. This is the graph that you've seen before that comes from the Johns Hopkins map, and I've presented this before. You can see this is as of this morning, over 460,000 cases in the United States and still growing. And as Marshall pointed out, we have over 20,000 cases in Michigan, and Washtenaw County is now 5th in the state in terms of cases behind Wayne, Oakland, Macomb, and Genesee counties. So as Vikas pointed out, we've seen some slowing. In discussions with CMOs at the other hospitals in Southeast Michigan, they've also seen some slowing in their cases there as well. As I have before, I want to give you an update on where we stand currently. And this is a graph that you've seen before and a chart that you've seen before. I will note, as Vikas has said, we've had 400 and some inpatients. We have had 26 inpatient deaths over the course of that time. But I think you're going to hear about some discharges that we've also had. And Vikas pointed out that we've had 178 people discharged as well. Current census is from this morning is 211 positive patients. And as you can see from the graph of our total positives, that curve is starting to flatten out. The map of Michigan shows you that this is still concentrated in Wayne, Oakland, Macomb, and Genesee counties, and Washtenaw and Livingston County, as Vikas pointed out, have a considerably slower rate of increase. And so we've been fortunate there that we've seen that doubling time increase. Things that we've been focused on institutionally over the last week since we last spoke. This is over 30 days that the command center has been up. So we have had some members of the command center rotate out and take some time off. And I think that's an important thing for us to consider across the organization as this is going to continue on for some time. So thinking about how we get some respite time, some rest, the ability to restore, so that when we come back to work, we're really able to continue to provide the level of care that we have been. So over the last week, I think you saw we've really worked on ICU capacity, and we've dramatically increased that ICU capacity. We've brought the CVC-5, 8D, portions of 8D, UH-PACU online, as well as activating 12 West and CNW. So really efforts across both hospitals and across the organization to be able to bring that level of ICU capacity online. And that was really focused on what the projected demand was. And I think you saw from Vikas's slides, we think that the social distancing and social interventions have really slowed the spread of the disease. Vikas pointed out that we've taken a number of transfer patients. The majority of those transfer patients have come from Detroit area hospitals in order to try and relieve some of the stress on those systems. And we now have a coordinated call with the systems in Southeast Michigan and the chief medical officers around understanding who's at capacity, who needs, who has capacity, and how can we help out across the system. So there's been great collaboration there. The other thing I'll say is we've had phenomenal support from our facilities teams who have been able to creatively deploy HEPA filters, so high efficiency filters to filter out particulate matter to increase the number of negative pressure rooms that we have so that we can get as many patients as possible in the safest locations. And you'll, I think, hear more about that. So they have just done a tremendous job. This data is a little bit old, but I think it's important to look at and represents the impact that social distancing and the stay-at-home order has had. This is from the New York Times, and the reference is at the bottom. And I think it's like a couple weeks old now, but this was data as of near the end of March. And I think what's apparent from this data, so the darkly colored areas are those areas that have not had a significant decrease in mobility. And the light colored areas show you where there has been a high decrease in mobility. And this is based on cell phone mobility data. So a little bit scary that they can tell where we are with our cell phones, but also quite informative. And I think what you can see is the Great Lakes region in New York really rocked it here, and tremendous reductions in mobility. And Washtenaw County, Livingston County, Macomb County were some of the ones with the highest reduction in mobility across the nation when you look at this on county by county data. And I think that really supports this, what has been contributing to the lengthening of the doubling time and the decrease of spread in the disease locally. So that's really figured into our projections and the flattening out of the curve. So as Vikas pointed out, we're kind of getting to the point where we think we're nearing the plateau. I think one of the questions everybody wants to know is when have we reached the peak? And I'll say that we haven't reached the peak yet, but what we are doing is starting to look at what the other side of the curve might look like. And important things for us to consider. We've made some dramatic changes across the organization, changes that have really improved the way we coordinate transfers, improved the way we've managed other parts of the organization. And we need to think about some of those things that need to stay when this pandemic and this emergency and crisis response is over. And so we're starting to think about those things. We know that we have deferred a significant amount of care in order to make capacity in the organization. And we're starting to look critically at what who those patients are and what their needs are so that we can start to move some of that care back in and make sure that we're avoiding harm on the other side of this as well. So we want to make sure that those things are balanced. I think there's going to be a long tail to this. So this plateau is going to last for some period of time. So we need to think about how to stay in this operational mode and start to move a little bit out of continual crisis management mode so that this is becoming our normal operations. And as we see hopefully declines in some of our census, we'll be able to contract back to those units that typically took care of those patients. I think one of the things that we have to be careful of, and we're looking for what those early signals would be, is to detect a second wave or a second surge in cases. And the governor extended the stay-at-home order through April 30th. So I think that's very good, and that will considerably help. But we want to understand from our data how we'd have an early sense of if things are changing and potentially going the wrong direction. I think that's really all I have. I think the other thing I would mention, one of the questions that's come up is, how long will we be wearing masks? And I think as I talked about, this is a long tail to this, and I think that we will likely be wearing masks in the organization and thinking about precautions in an enhanced way for quite some time. We really don't know what the population or what the prevalence of the disease is in the population, but we're going to want to be careful of that and be cognizant of that. Final thing that I would just comment on before I step down, and we'll have questions at the end, is people have asked, what can they do to help? And we've certainly had tremendous outpouring of support, as we've said before, from the community. One thing that I would highlight today is blood donation. And I think those that are able to should make an effort to try and donate blood. You can call the Red Cross and they can make an appointment. So they are collecting blood and blood donations with social distancing. But I think it's an important component of this for us to maintain that blood supply. We've continued to focus on access to supplies and PPE. We're lucky that we have not had any instances in which people don't have access to the PPE that they need. We've gotten fairly tight, to be honest, with what our PPE supply has been in a couple instances, but we've never run out, and we see some increased robustness to that supply chain. So we're starting to feel good about that, and we'll have to continue those efforts again, as this is going to be a long tail as we move into kind of continued operations in this mode. So with that, I'll step down, and I think Nancy May is going to come talk about new staffing models. Thanks.
So thank you very much for the opportunity to come up and talk about our staffing model. Last week, we launched a new staffing model for the pandemic, and fears that we would have hit the peak last week. What we have found is that we've done such a great job proactively managing ICU beds into the organization with the ICU expansion that we really never got to what I would say pandemonium, which oftentimes we see in the media. We did launch the model of care, and it was to really make sure and ensure that we had adequate staffing as patients came in. Our ICUs, with that expansion, we needed to put moderate care nurses into the model, and then they got pulled out of our general care staffing areas. We look at this model every day. The ACNOs and the CNOs meet and are active participants in looking at how to manage staff and move staff to appropriate levels. Like anything new, you have to go back and do your plan, do, check, act to see where you're at and revise as needed. And so what we have done is really take a look at some of the concerns that come through, sometimes from frontline staff, sometimes through our physician partners, sometimes just the word on the street where people are having a difficult time. And then what we do is we then pull together and figure out how we can support. So last night we had a call out for SICU, and we were able to redeploy some people into that model. They have a high acuity level. We take a look at the acuity of those levels and we move staffing around to ensure that we can provide safe care. The models are working, and it's only because of the flexibility of you, our nursing staff, that continue to go up and over and above and beyond to provide the best care in these challenging times. So that I thank you for. We will continue to look at the model, and as we now have plateaued in the surge, we will figure out how to reinfuse our nursing staff back into their general care areas as well as into the ICU. So it's something that we work on every day, and we'll continue to throughout this pandemic and back to business as normal if we ever get to business as normal again. One of the things I'd like to highlight a little bit, last week we were up and talked a lot about our inpatient areas. I'd like to give a few shout outs to our ambulatory care areas. We've had many people volunteer to be redeployed, and I thank you for that. We also have them manage the triage line, which keeps people out of the ED, and we're able to manage patients through remote and televisits that get escalated to our providers. We've also stood up actually 3 COVID drive-thrus. That wouldn't be possible to get the testing done in the community without those. Previously, they were managed by our APPs, and we've moved our APPs into work that's more appropriate for their skills and education. They've also stood up a COVID hotline, which is 7 days a week, that provide community service to people who have questions regarding symptoms of COVID. The field hospital, we haven't really talked about that too much today, but we do have a large group of people that are working on the field hospital at one of the athletic campuses to stand up if we need to. They've put in countless hours in planning, and it's been great. And even if we never have to use it, it's been a wonderful experience for disaster preparedness. I also want to, again, give a shout out to the military nurses that have been so valuable in this process and have volunteered to stand up. I'd like to show some pictures of our nurses and our care teams. during the short time that I have left with you. Many of them are frontline staff, and they've done an amazing job. This pandemic is like no other epidemic we've seen in our modern times. It's been faster, more deadlier, and far more widespread than we've ever seen in the past. And we are responding in kind. We are moving faster than we ever have. We are coming together in ways we never thought we could. And we are caring for more of the sickest patients. While this situation is heart-wrenching and oftentimes heartbreaking to our frontline staff who have moral distress as they care for these patients, it also so deeply defines the role and the purpose of nursing. Amidst the very difficult and complex challenges we face every day, I would encourage the nursing community to pause and reflect on our purpose. Be super proud of the work you're doing and what we accomplish as a collective team. In these times of crisis, we are exactly where we are meant to be. I love this one. We are all in this together. When we work for common good, we experience each other in new ways. We don't worry about the differences, status, or traditional power relationships. We worry about whether we succeed in accomplishing what needs to be done. And that's Margaret Wheatley. Thank you.
Good afternoon. My name is Vineet Chopra, and I am the Chief of the Division of Hospital Medicine at Michigan Medicine. Our leaders asked me here today to offer some reflections on our journey so far on COVID-19. I would like to take you back a few weeks ago to the early days of this pandemic. At that time, I received an email from members of the command center asking for our hospitalists to stand up a team that would care for COVID patients. I struggled with this ask. How do you ask your colleagues to step into harm's way, to fight an unknown threat? What are the words you choose? How do you acknowledge the fear and the anxiety that might create? Turns out I need not have worried. Within one day, 12 of our hospitalists had stepped forward to take on these early cases. We reviewed how to don and doff PPE, learned as much as we could about the virus, and agreed to provide 24-hour coverage for these patients, aiming to protect others as much as we could. I want to emphasize that all of us were volunteers early on in this process. No one forced them to do this. No one paid them to do this. It was quite simply the right thing to do. Over the next few days, we admitted many COVID patients to dedicated negative pressure rooms across the hospital. These were the early days. Tests would take 1, 2, sometimes 3 days to come back, and you never knew if the person in front of you really had the disease. Patients often thought they knew, however. I remember one man who said, "Hey doc, I don't really have this virus. This is just my COPD." He was right. Others would be more cautious. What if I have it? What does this mean for me? Could I die? And what about my family? I wish we had the ability to provide our patients with answers. I wish we could tell them at that time that we, as your providers, also shared your fears, not just for you, but also for us. As the number of cases began to grow, we realized our approach of placing patients in rooms across the hospital was not working. It was not efficient. It risked exposing people in different units to COVID, and we were running out of rooms. That was when we began to activate the Regional Infection Containment Unit, or the RICU. Now, I've been at this organization for many years, and I have never seen us move as fast as we did when we activated the RICU. Our leaders came together, our clinicians came together, and our front lines came together. I asked 2 of our hospital medicine leaders, Dr. Valerie Vaughn and Chris Smith, to help me co-direct the RICU. Together, we developed a mixed model of care, adult and pediatrics, critical and non-critical, all within the same space footprint. Within 5 days of saying go, we opened our doors to patients with COVID-19. 5 days. How could this have happened? How were we able to do this? I believe this happened because of our team. The RICU represents the best of what Michigan has to offer. Adult physicians, pediatricians, intensivists, anesthesiologists, nurses from across the organization, respiratory therapy, infection prevention, pharmacy, infectious diseases, social work, physical therapy, health IT, facilities, environment, many more that I can't list. We all came together for this heavy lift. And many of us who did this were volunteers. It is nothing short of a Michigan miracle. We have taken care of many patients in the RICU, and I want to end by telling you a little bit about these patients. We saw the very old and the very young, suspected and confirmed cases, the critically ill to those less ill. We saw expectant mothers, elderly grandparents, couples and family members and children. We saw healthcare workers, our colleagues, and our friends. This virus spares no one. Our patients would quickly mount high needs of oxygen. They'd become more breathless and they would need invasive support. They were often alone at this time of greatest need, and many of us became their friends and their families. And while some of those patients are no longer with us today, many, and I repeat, many have walked out and have been very grateful for the care they have received in the RICU and beyond. I want to use the words of one recently discharged patient to end, who said, "Thank you, all of you, for saving my life. We did this together. We are in it together. We will get through it together." And now I want to share the podium with other frontline heroes who have helped me in this journey. Thank you.
Hello, my name is Marianne Adamczyk. I'm part of the nursing leadership team for the RICU. We were asked to come and share our story with you. I'm going to start by going over what has worked, and I'm going to echo some of the things that Dr. Chopra already said. In terms of what has worked for us really well, from the very get-go when we had our pre-activation meetings, the willingness of our colleagues to come to work together shoulder to shoulder with us to successfully change a 32-bed pediatric unit into a 32-bed ICU and up to a 50-bed ICU was just incredible. They brought their talents, their suggestions, their creative solutions, and we all built that unit together. In addition to that, we could not have launched this unit without our nurse and tech volunteers. Many of them were on overtime over appointment, and they came over and over again to work the shifts to make sure that we could provide the best care to the patients that came to us. And lastly, I think what worked was our nursing leadership in terms of the support they gave us. We started with bringing our clinical ICU leaders, Laura Baker and Noel Baldwin from our other units. They were established experts and helped us make sure that we had everything in place clinically to take care of our patients that were coming. And also, I'd like to thank especially our leaders, our CNE, our CNO, and our associate leaders, especially Julie and Kelly. They kept us supported. They gave us what we called sacred time, and they always came and talked to us and made sure that we had everything we needed. In fact, all of the department leaders would stop in and say, "What else do you need?" And we truly, truly appreciated that, including the physician team and all the disciplines that were in the RICU. And I'm going to now have my other leaders come and speak to you about other facets here that we experienced.
Thank you, Mary Ann. I'm Julie Juneau. I'm another of the nursing directors for the RICU. We came together quickly as a team, as she said, and the majority of people being volunteers had a really committed focus. We were there to do the work that needed to be done. But although things came together very quickly, we did have some challenges. One of the first things that we realized when we moved from a 32-bed unit to a 50-bed unit is that we had outgrown the capacity of one of the vital functions, which was the vacuum or the air that we needed to use for suctioning. But again, looking to the people who were doing the work and including their creative and innovative ideas, we were able to come up with some solutions and found a way to handle it so that we could keep running smoothly. One of the culture pieces of the RICU that we used from the beginning was negative pressure, positive attitude. We always worked to see what we could do to keep moving forward, to stay calm and creative and working together, because everyone was a brand new team every day, but worked seamlessly together. Another one of our challenges was communicating inside the negative pressure rooms. So we had to go through some trial and errors with using the call system, learning how to use cell phones, learning how to do FaceTime with the patients and their families so that we could include them as well, and also using two-way radios and other communication devices. The last challenge was because, as Marianne mentioned, that we were an all-volunteer nursing crew, we never knew who exactly would be coming the next day. We didn't have a core number of people assigned to us. We knew that we needed to create that core in order to be able to stabilize the unit. And one of our other colleagues, Alex, our supervisor, worked very hard to create the nursing team plan that helps us be able to establish the core and work safely.
Hello, I'm Alex Gill, the nursing supervisor for the RICU, and I just want to take a moment to recognize the outpouring support that the RICU received from our nursing community, with over 250 nursing volunteers that all came above their appointment to help get the RICU started and support our patients that we were receiving. I was brought in to do the scheduling for the RICU, and quickly it turned into working on a whole new staffing model across the institution. And I just want to recognize the flexibility of all the unit leaders, all of the nurses. They really came together and worked well as an interdisciplinary team to support the development of the RICU and expand even further across the institution.
Hello, my name is Jacob McSparron. I'm the Associate Director of the CCMU and of the RICU. Just to speak a little bit about the critical care needs in the RICU, the last few weeks has been a very humbling experience for all of us, very humbling for myself. I think from very early on, it was obvious that the team was a key part of this. I want to emphasize that the true frontline providers are the people spending the most time in the rooms, the nurses, the respiratory therapists, the techs, the physical therapists, pharmacists, environmental services, and many more people I won't list. It was clear very early on that this was going to expand quickly. We started off as consultants, critical care consultants, working with the hospitalists, with one person working day and night and taking home call at night. Within several days, it was obvious we needed in-house intensivist coverage, so the pulmonary and critical care faculty set up one intensivist in the day and one at night. And only a few days later, we realized we were going to quickly expand up to 50 beds. So now, moving from 1 and 1, we have 4 daytime intensivists and 2 nighttime intensivists, in addition to many pulmonary and critical care and anesthesia surgical critical care fellows. We really enjoyed working with the hospitalists as consultants, and we were very, very sad to see them leave, but we recognized they had patients to take care of on the floor. And it's been amazing watching the anesthesia group, the residents, the CRNAs, the APPs, who have really risen to the challenge and become the primary providers on the floor in the RICU for these patients. We have a really incredible partnership with surgical critical care and medical critical care. Dr. Ross Blank is the director. I'm the associate director of the RICU, and everybody has really been working together like never before. I will say it's hard working up there outside of our normal comfort zones. These are not our home units for anybody, and there's different environments. We're not able to do the things we normally do from day to day, from hour to hour, from minute to minute. And clinically managing these patients it's been unique. We're used to taking care of very sick people, a lot of patients with respiratory failure, but taking care of patients and also thinking about minimizing PPE and minimizing exposure is really challenging when we're used to being at the bedside in the patient rooms almost continuously. One of the most challenging aspects for all of us is not having the family and loved ones of the patients at the bedside. We rely so heavily on them, and it makes all of us feel better when we're able to communicate with family members. And not being able to do that is a real strain on us, as providers on the front lines, and that's something we're learning more about every day. As you've already heard, within the span of a little over a week, we went from 2 mechanically ventilated patients to a census of 50 with about 40 mechanically ventilated patients in the RICU. I don't think any of us really expected for things to go that quickly, but it was something that we rose to. And we've rapidly developed unique experience taking care of these patients. We know that we're not unique in the RICU, as the CCMU, the NICU, and many other units are taking care of COVID-positive patients. We're all working together to share our collective experiences, and we're trying to disseminate protocols and information from the RICU and the other units to all over the hospital as more and more providers have to take care of these COVID patients. And I think the last thing I'll emphasize is as we've expanded, it's really been incredible to watch. We're now over 200 ICU beds, and we're ready with provider teams who are ready to step up and take care of these patients. Thank you.
So thank you to our frontline heroes. And as Dr. Runge mentioned earlier today, we have a special surprise. On behalf of Michigan Medicine, I'm happy to announce that our very generous donors have contributed just under $700,000 to support employee safety, wellness, and recognition of our frontline staff. While we have some things already planned, we want to hear directly from you on what would be most meaningful for how to use these funds. So we will send out an email on Monday through the global user and headlines for ideas. So please do think of how we would use these funds for you on the front lines, and we look forward to hearing from you when that email goes out. Thank you all very much.
Good afternoon. I'm Dolores Hunt, Chief Human Resources Officer. Let me just start by saying thank you. Thank you to all of you who are on the front line. Thank you to all of you who are doing work from home and all of you who are volunteering. I want to talk a little bit about our people because our people are our greatest strength. And so to all of you, we thank you. And just to show how strong we are as a unit, let's talk about redeployment. When we put out our notice that we were looking for people to be redeployed, in less than a day, we had hundreds of people come forward. So we realize that you are here to help, and we appreciate that. We have moved from a voluntary process to a mandatory process effective April 1st. All hands on deck. And we know what that means. That's a call to action that we need you to be present and a place at a time where you're needed to help our patients and help each other. So our HR team, our UMG team, our nursing, our advanced practice teams have all come together and started to get requests, and you've started to answer those requests and those calls to move forward. Again, just by putting it out there, we had volunteers. And now we have over 2,000 employees who signed up to be redeployed wherever they're needed. And so we can't thank you enough. However, we know that when it comes to a hard time, it can be difficult for some to accept assignments. But we all know all hands on deck means all hands on deck. We don't want to go in a direction of discipline, but that's a possibility. But we want to listen to your concerns before we move into that area. With regards to return to work, we have heard how many people have been infected by this disease, and some of them have been our own. So what we want to make sure occurs is that your return to work after isolation, what's expected. We expect for you first to be cleared by our OHS team, but be free of us for 72 hours with no fever and improve your respiratory symptoms. At least 7 days since the symptoms first appeared. Again, we have a team that's on staff 24/7, and our OHS team is working daily for you to come in and go through the process. After returning, we often hear, and Dr. Desmond's mentioned, how long do I have to wear a mask? We ask that you wear a mask until further notice, and we'll make a system decision about that where we are with this crisis. We restrict contacts with serious immunocompromised patients for 14 days. And again, we've all heard, wash your hands, cover your cough, cover your cough. Self-monitoring systems are always required. Some of the things that has happened since our last town hall meeting is you heard that our governor was on the news yesterday talking about some changes. But I want to make sure that everyone is still aware of our special benefits that's been put in place. March 13th, the University of Michigan put in place a COVID bank for 80 hours. This was the first thing you probably heard that a health system had done this or a university. So collectively coming together to support all of our employees. Michigan Medicine also implemented a 120-hour bank for any of our employees who may become in contact with the virus. On April 1st, the governor announced some additional benefits, another 80 hours of time off for employees for expanded emergency sick leave. And then that expiration date for that is April 30th. So we need to make sure that you're aware of these dates and times. We also have available a COVID-19 supplementary bank that's available. Expanded medical leave, and this is for child care purposes. And it's a 10-week program that can pay you up to a maximum. All these questions have been in our HR FAQs, and we ask that you refer to those for details. And if you don't find what you're looking for, please reach out to your leader or to your HR business partner. We are concerned about your care, and so we look at how we can help you and be supportive of you. We are grateful to all our donors for all that they're doing to help, but we at Michigan Medicine also are there to help you. So we also want to make sure that you know about our Office of Counseling and Workplace Resilience, our employee support team, our spiritual care team, Healthy, and our University Psychological Clinic. All these things are available for your use when you need them, if you need them, or if you see one of your colleagues who might be in need and just need to talk to someone. Please refer them to this information. And again, all this information is also listed on our website and our FAQs. I can't thank you enough for all that you've been doing, and especially those who are interacting daily with our patients. Thank you for all the sacrifice that you are doing and you're giving, and thank you as you help others try to fight for their lives. Again, we are all in this together, and we're here to help. Thanks.
Good afternoon. I'm here to begin to get your questions answered. As I said last week, I have well over 75 questions here and more on the computer. So what we will do is go through as many as we can, and then the rest of these we will try and answer throughout the week with our daily updates. We will list the questions and begin to answer those. I think I'll start with Nancy to talk about nursing, the number of nursing questions. So when we start there. So how are nurse staffing needs being decided? Some nurses are begging to work and being sent home while others are being overworked.
Sure. So it goes back to the staffing model. We put the staffing model with the best plans intended that we would have a huge surge of patients last week. And by putting that staffing plan together, we could ensure that we had frontline care teams able to care for those patients. As we have seen the plateau starting to flatten out, the Nurse Executive Council has been meeting and looking at the model and making revisions to the model where we can. There's also really going through the standard operating procedures on how you should assess your staffing needs and then call down to the staffing office, talk about your excessive staff, have them go down there so we can redeploy them to other areas. So we're going through those standard operating procedures with our leadership team to ensure that everyone is following the same process. When we have areas that are in critical need, they just need to ask. We do have some excess of staff on some days, and we will redeploy those into those areas. As we continue to get out of the pandemic, we will once again infuse our nurses back into their departments. I really cannot express how much I appreciate the flexibility of the staff. These are not easy things to do. And coming together as a whole community of nursing has been so amazing. And I could tell story after story on where a moderate care nurse went to an ICU and talked about the team collaboration and how open-armed those ICU nurses were to those moderate care nurses. There were extra set of hands, and it's opening opportunities for us to actually grow more ICU nurses, which is great. In other areas, I've heard that from a few, not a whole lot of people, but from a few struggles that they didn't have enough staff. And so once again, messaging to our nurse leaders, if you need additional staff, we will redeploy staffing into areas and infuse once again our nurses into areas that they are needed to make sure we have safe care.
So as a follow-up, are nurses being asked to perform duties, tasks that they are not trained or comfortable with?
So we have CNSs and we have educators on every unit. Granted, they are here during the day, but if you are on an off shift, then certainly reach out to the charge nurse. We will make sure that, we can help you through care delivery for that patient or change your assignment.
And why is the nursing staff model only implemented on some units?
So that's a great question, and one that we're talking about, actually. I think the consistency of how we do things fairly across all areas, we've talked about with the Nurse Executive Council. It was brought up again today. They are actually huddling now, where they used to do bed meetings, and talking about having the charge nurses call in their needs so that we know across the board that we have a uniform way to address it.
Are there nurses being furloughed, as far as you know?
Not that I know of.
And there's been nurses that have been terminated if they refuse to work with a
So I would say
COVID.
I haven't really had a nurse refuse an assignment. I think people are scared, but I think the more people know about the pathology of the disease and how we can protect ourselves, and the more educated we can help demyth some of those fears. I would say if someone refused an assignment, we would follow our HR contract.
That's all I have for you, Nancy.
Oh, good. Thank you.
So I'll go through a whole set of questions here, and actually I think I can answer most of these, but I may ask for a couple people when I get to them. Since we haven't seen COVID patients in the numbers expected, why are we still using the surge staffing model? I think, first of all, the model that we've used that was developed with Vikas has predicted fairly well our volume, and it's only been in the recent days that we've seen a flattening of the curve. We all hoped for flattening the curve, otherwise we were going to completely run out of general care beds and ICU beds. So so we have used the surge staffing as we update the model with volumes that are coming in. Then we will then begin, as Jeff talked about, the other side of the curve. How do we begin to bring in patients we've delayed care in order to and bring them back into our system? It says, what is our PPE inventory, and are we worried about running out? Jeff, you want to take this one?
Yeah, thanks, Dave. So PPE is an ongoing question, and what our PPE inventory is a difficult question to answer because it's a single point in time. As I said in my earlier comments, there were times when we got pretty tight within a couple days of PPE for certain supplies. That said, our supply chain is more robust now, we believe, and so we try constantly to stay ahead of that. I think the best answer that I can give you is we have adequate supplies of PPE right now. We know what our utilization rate is. What is not known very well is what the resupply rate is. So we try to stay on top of that and be careful about our use of PPE so that we will have enough to last us through this pandemic. The other thing I'll say is around N95 masks, one of the things that's really going to help us is the reprocessing that we've started. And so we're reprocessing a number of N95 masks through a safe and reliable process and are able to get those back to the unit so that they can be reused. That really gives us a cushion in our supply chain so that we can maintain supplies throughout the pandemic.
So the other one is, on average, how long are COVID patients, in the hospital? What's their average length of stay?
So right now, the average length of stay, I'm going to look for some friends in the audience. I'll phone a friend here, but average length of stay for general care patients is about 5 to 6 days. For our ICU patients, it's around 9 or 10 days now. But that's with a caveat that we're early in the ICU population. And you saw from the earlier data, the number of transfer patients that we're taking that are in the ICUs. And those ICU patients have a long course. So it's not going to be for a while till we start to see some turn of those patients and some more patients that are getting to their entire course in the ICU to really know what that is. But those are the numbers that we have right now.
And you and I talked about this. How many COVID patients are being seen in the ED without being admitted per day?
Yeah, so we've seen the total number of, so first of all, the efforts that have been made in ambulatory care and other parts of the organization and the stay-at-home efforts and social distancing and the communication about using the emergency department for appropriate indications has really been effective. We've seen about a 50% reduction in our ED visits overall. We've seen a number of COVID patients that have been coming to the ED. I think because people know with mild disease, they're not going to have specific treatment in the emergency department or require hospitalization, we don't see that many patients with mild disease in the ED. So our admission rate for COVID patients in the emergency department is about 60 or 70% of those that come to the ED with COVID symptoms end up in the hospital. And I think that's, as I said, because we're seeing the more ill patients there. That said, the total number has started to decrease. And I think the most recent numbers are around 8 or 10 patients a day that we're seeing in the ED that are requiring admission, and I think that number is declining.
So there's a couple here about transfers. Why aren't we taking more transfers to help out hospitals that are overwhelmed? And I would say we have, but...
Yeah, so we've taken a large number of transfers, and as I said earlier, those are really focused on the hospitals in Detroit where they're feeling the greatest need. We have a robust transfer process, and we have completely redesigned that to align our emergency department to emergency department transfers, as well as taking patients from other hospital emergency departments to our inpatient units, as well as, critically ill inpatients to our inpatient units. So we evaluate each one of those transfers on a case-by-case basis, but we take the vast majority of transfer calls that come to us. We do decline some patients when it seems that we don't have something to offer them that would be different than the care that they have at their home institution. But also, as I said earlier, we've had some really increased collaboration around the region from a hospital to hospital and system to system basis. And we're very transparent now about who has capacity, what capacity do they have, and then who has patients that need to move. And we're trying to really balance that out in a better way.
Yeah, the other one is a theme here. Do you anticipate an increase or decrease in transfers now that the TCF field hospital in Detroit is accepting patients? And we talked about this morning.
Yeah, so what people are referring to is there's a large field hospital that's being deployed at the TCF center in Detroit. That will actually go live. I think today they're taking their first patients, and they're going to take 25 patients a day until they get up to a census around 250 and then reassess. They have the capacity to be as large as, I think, 500 to 1,000 patients. That said, the need for that facility is changing as the disease changes in Detroit and in the Detroit area. So in our discussions with the Detroit hospitals, what they're seeing a need for is longer stays in general care, patients that need convalescent care. And so I think the need of that TCF center as being an offload for the acute hospitals is changing. And it's going to change more to a location where patients that need that either can't go home because of social reasons or other reasons at home or need longer convalescent care are going to be going to that center to offload those other hospitals.
I think how are we helping our communities in Detroit? I think we've already answered that. I think you have your daily or your CMO call with the state.
Yeah, so we've done that with taking transfer patients. We've done that with sharing expertise. We have really had some great efforts by many to put together websites that have critical care resources and plans for care that we share with others. And then we've also helped with some testing capacity and being able to offer testing to other locations.
I think that's about it for now.
Great.
So another question that came up is, will we be able to screen patients and employees for potential antibodies? So we have a task group who is looking at this. It's being convened by David Miller and includes a number of people from pathology to look at what is our strategy for testing once the antibody test is available, which we anticipate in a couple weeks. And that along with the PCR testing to figure out who's had COVID, as well as who is currently, who is shedding virus, both to protect our employees, but also to enable us to decide who can or should come back to work. That we expect a report out sometime next week as to the strategy for that test. Another person asked if you can donate blood if you've actively cared for COVID patients, and we've been told yes, you can. Another question is, why are patients known to be COVID positive in an isolation room not required to wear a mask? And I think we had this discussion, Lorraine and I, just earlier today. I think we will relook at that question. Previously, it had been related to their breathlessness and the effect of the mask on their breathlessness. I think we will readdress that in our command center and see whether that is possible in order to better protect our employees. But I think it had mostly to do with the breathlessness. One said, do we anticipate a spike in new cases once the stay-at-home ends? So I don't know. We don't know when the stay-at-home ends, and that's what we want to try and avoid. I think that what people are discussing is whether when we lift the stay-at-home, when we have adequate testing, that we can test who has antibodies, we can test who is infected, and we can then begin to actively trace active cases so that we can prevent another outbreak. And I think that's what we're hoping will happen when the stay-at-home is lifted, that we have adequate testing, that we can track every individual case and every contact in order to try and keep from having another outbreak. We're down to what, 1 minute, right? 3, okay. Are the deaths all confirmed to be strictly related to COVID? I said, that is not clear. I guess what you're asking is COVID-related deaths. I think they use the term COVID-related because they could have had other underlying medical problems that also contributed to that death, but they have a COVID infection, and not all deaths that people die at home, and others we don't know at the time whether that's related to COVID. And I think the rest of the questions we'll try and answer on our updates that come out through the week. I want to thank everybody. You've heard everybody today. Thank all our providers, all our nurses, our physicians, physical therapists, respiratory therapists, and environmental services staff. We're all important in trying to keep each other safe and keep our patients safe. And as you heard, Vineet, the teamwork that we've seen responding to this pandemic is just outstanding, and it is Michigan medicine at its best. Thank you again for taking your time to virtually come to our town hall. and we'll see you again next week. Thank you.